in various structures later in the program. So moving on with the next talks, and it's my real privilege to introduce Professor Simon Marr, who is going to give the next talk about how to perform first trimester neurosonography. Simon doesn't really need an introduction. He's very well known to all of us. He is the chair of the ISWA Courses Task Force, who's now become the subcommittee in the education subcommittee for the courses. And he's really, having sort of personally worked with him for a few years now, he is extremely passionate about education. He's done a fantastic job with ISWA courses, and we are extremely grateful to him. He joined recently as an ISWA trustee. Simon is the medical director of the Monash Ultrasound for Women's Health, and so just highlight one aspect of his fantastic career and fantastic achievement, that he's has won the award of the Sonologist of the Year by the Australian Society of Ultrasound in Medicine. So we look forward to listening to your talk, Simon.
So next I just want to do is the intracranial translucency measurement. So I just do a sweep of the baby's head from top to bottom on the fetus. And then when getting the intracranial anatomy, I like to get the head, so I've got the occiput up at 12 o'clock, the symmetry of the brain, and then I sweep 90 degrees to that, and that will bring me my landmarks in very predictably. That's my preferred way of getting intracranial translucency, rather than just randomly taking a sagittal image. And then we see these landmarks coming into view here, which is the brainstem here, and then this here is the intracranial translucency here, and this here is the cisterna magna. So you can see all these lines and spaces. Now in terms of just tidying up that, we'll just come out of that magnification, because I think a lot of people do, when they're looking at it, they go for a nuchal translucency. Simply you put your probe on the abdomen, find the sagittal fetus, and then hope that you get your intracranial translucency. Now sometimes that'll work because the nuchal translucency and the brain landmarks are all in the same section, but it doesn't always. And that's why I encourage you is to come around to get this section where you have an axial section through the fetal head with symmetry of the choroids. Now you can see the baby's moving, but that's in a sense why it may be difficult measurement to obtain just going straight to sagittal. Whereas you go to axial, and I have symmetry, and I'll split it for you. You have a perfect axial section with the symmetry of the choroids, and all you do is just flip your transducer 90 degrees to that, and then all your brain landmarks come into view. And you can see it's not a perfect sagittal because, quite frequently in getting these brain landmarks, it's parasagittal or it's oblique, and in this case it's slightly oblique. So it's absolutely right for measuring the brain, but not perfect for measuring the nuchal translucency. So that's the most predictable way of getting the intracranial landmarks. Then once I've done that, I've taken my measurements. See the baby's rocking, rotating now. I can then magnify the image. I then look coming across the calvarium, which is ossified. I look at the choroids, which are very seldom perfectly symmetrical. They're also quite irregular in the first trimester. I can see the midline falx. I then come down to the brain stem, and I'm getting reverberation in terms of trying to see the aqueduct, which is just here, and the cisterna magna. Now this is not an ideal position for looking at axial. It's in a very good position for me doing a sweep to get my sagittal section, but it's not good for the transverse. So I'm going to make it such that the fetus is in a transverse position. Now this will be much easier to see the rest of the brain. So I'm going to increase my dynamic range. I'm going to pull back a little bit. Sorry, my gain. I'm going to pull back a little bit my dynamic range, bring it back to 6. And now my magnification is correct. And I'm going to start off by looking at the choroids. Come down then, I see the little fluid-filled space, the cavum velum interpositum. Come down to see the box of fluid, which is my aqueduct of Sylvius. Remember, when looking at the midbrain, do not have any choroids in view. Okay, so that's not what you want when taking an aqueduct of Sylvius measurement. I've rotated my probe to produce that for you. I'm now going to rotate it back. You now have the aqueduct in view with no choroids in sight, and it's at that point that you measure the distance to the occipital bone. and then I go inferior to that, and then I see the choroid of the fourth ventricle. Once you've done all of that, you can say, look, listen, I'm going to split that up into 4 sections. And to do that, before I split into 4 sections, I'm just going to change transducers, and I'm going to move to a higher frequency transducer. And this is a 9 linear transducer, selecting obstetric and selecting first trimester. A little bit more gel in the abdomen, because I'm using a fresh probe, which is dry. And then I place the probe on the abdomen, and I now take a transverse section, and I hope you appreciate the detail that you get in a sweep is clearer, because now I can see the cerebral hemispheres, I can see the cerebral mantle. As I come down, I can see the cavum velum more clearly, I can see the aqueduct, and then I can see the choroid and the fourth ventricle more clearly. And when I'm doing this, I like to, again, as a training thing, it's a good idea, is to magnify up and then go through the 4 sections, just showing all these landmarks. And that's the cord there. I should have shown a little bit more fluid in the aqueduct, but that's the aqueduct to the occipital bone distance there. This is the measurement of the fourth ventricle, and then you can see your choroid and your cisterna magna. So it's just clearer images, I think, that you're getting with this. And then if you want to, you can then split your image at the very end into two, because the 2 most important measurements that you're going to take here is the measurement of the aqueduct, the occipital bone is the most important. And then the second one, the next important measurement, is take a measurement of the fourth ventricle. You will note that there is no cavum septum pellucidum, because at 12 weeks of gestation, there is no cavum septum pellucidum. So how do you know you're going to take the right section for BPD? Well, you come down to the midbrain until you get the aqueduct. You've got no anterior landmark. So the only way you know that you're actually the right section is by seeing perfect symmetry of the brain, so that the right side of the brain equals left. That's an important part of taking a BPD. So it's not an oblique section through it. Number 2, that you have the falx in view, and where would be the CSP, which is not there, not visible, and then you measure the posterior border into the inner border of the occipital bone. And that is a measurement that is looking at the 4 sections of the brain. You can also look at the brain in this section, and it has been described by Eagle and colleagues by looking at the intracranial translucency in this position. It's a harder position to obtain, but these here are your landmarks. So this here is your brainstem, just here, and this here is your intracranial translucency here, and this here is your cisterna magna here. So you can get used to looking at it in that section as well. The advantage of this section is that it shows you the lateral ventricles being symmetrical on each side more clearly, I think, than in a transverse position. It shows the choroids more clearly, but for the midbrain, the posterior brain, I think you're better off having it in a transverse position. So that's, in summary, the completion of the brain. I can show it to you as a sweep through all the sections, showing that section, coming down, showing the midbrain, showing you the brainstem, fourth ventricle, cisterna magna, and then we go around doing the same exercise, showing the choroids, showing the cavum velum interposum, which is quite tiny in this baby, and then the aqueduct of Sylvius, and then moving down onto the fourth ventricle, and then go back up. We show getting the position of the head so that the occiput is up at 12 and it's very active. So once it's in that position, once I've got perfect symmetry, about 12 o'clock I flip 90 degrees, and that's where I expect to see my landmarks. And I'll go into a split image here, coming down here, and I'll show you that that's slightly different to obtaining your profile view. If I just rewind that, I think at the very beginning it showed. So there's your 2 lines of the equal sign of your nasal bone, and that's where you will take your nuchal translucency measurement. But the point I'm making is that that's at a different position for measuring your brainstem, your intracranial translucency, and your cisterna magna. You can magnify that image, get rid of the markers, and those you can take your brainstem to the occipital bone distance. So you can see your profile may not always produce your landmarks, and then increase your dynamic range. You can always just sharpen up the image. And the last marker to mention is the maxillo-occipital line. When you draw a line along the surface of the hard palate superiorly, this is the sphenoid bone, the line should go above this and then straight on to the occiput. And this line in a normal fetus, the junction between the thalamus and the cerebral peduncles, which is exactly this point here, lies above the line, whereas in spina bifida, this junction lies below the line. And I will talk more about this in my talk on spina bifida next. In a recent study from 2021 published in Journal of Ultrasound Medicine, this finding was seen in 100% of a large series of spina bifida. So it's worth taking note of this. You will ultimately reach the point where subjectively you can see the junction lies above this line rather without having to physically measure it. So lastly, I'd just like to say a few words about the brain anatomy around 10 weeks of gestation when we draw blood for cell-free DNA, which we do as a first-tier test for many units in Australia. And I'm sure there are many other units globally who are offering NIPT at 10 weeks. The brain looks different at this stage. So you just sweep through the brain at this stage in a fetus at 10 weeks and 5 days. Just to mention one or two things. The first is that the fourth ventricle looks disproportionately larger when compared to the calvarium at 10 weeks when compared to later. Also, the lateral ventricles occupy the anterior 3/4 of the calvarium, whereas at 12-13 weeks it extends more posteriorly. So this here is the lateral ventricles in a more anterior position. The next, when you move down from the lateral ventricles, you will see that the third ventricle is larger at this stage, reference to the head size. The aqueduct is larger, reference to the head size, but the aqueduct is juxtaposed to the occipital membrane. In a sense, juxtaposed to the occipital membrane. In a sense, that juxtaposition, which we've described as a marker for spina bifida 12-13 weeks, every baby at 10 weeks of gestation looks as though it's got midbrain displacement. And therefore, you can't use midbrain displacement or the crash sign at 10 weeks because that's how a normal brain looks. It's an important point to make, and I'll make reference to this in my talk on spina bifida. And then as you move inferiorly, you can see then the choroid in the roof of the fourth ventricle is less hyperechogenic when compared to 12-13 weeks. And sometimes the fluid around 10, 9, 8 weeks, the rhombencephalon, is a very striking structure. So these are important points to make, and I will just to demonstrate this divide this into 4 quadrants. So if we come up to the first quadrant in the top left-hand corner, which is total zoom, so it occupies the entire quadrant. This is the more anterior positioning of the lateral ventricles, the midline phalanx. This is the third ventricle. This is the aqueduct, the cerebral peduncles, the thalami, juxtaposed to the occipital membrane. Do you see how posterior it is? And then slightly inferior to this, then we have the fourth ventricle and the roof of the fourth ventricle. You can also move on to looking at the maxilla and the mandibular gap, which is present and can be seen in fetuses at this stage of gestation. So I might stop there and then hand over to Rabbi, who will be talking about the 3D evaluation, which I've left out of this talk for Rabbi to cover. And now I'll move on to my talk on spine.